Hello and welcome to PCR Webinar, How Should I Improve the Results of Provisional Sideburn Stenting? My name is Goran Stankovic, I'm interventional cardiologist from Belgrade, Serbia, and I have really great pleasure to have excellent faculty today to discuss it with Professor Jens Lassen from Denmark and Professor Dejan Milašinović from Belgrade, Serbia. And I'm really happy to offer you this year in a new series of webinars discussion of pitfalls of different bifurcation techniques. Last year, we went step by step through all different provisional and two-stent techniques. This year, our goal is to focus on pitfalls. Today, we discuss the pitfalls of provisional, and if I can have the slides, our goal today is to try to help you understand how to correctly perform stent optimization techniques, to help you learn how to optimize side branch result in the provisional strategy, to learn how to address technical pitfalls in provisional side branch stenting, because simple does not mean it's not challenging, and to discuss why provisional is recommended for majority of bifurcation cases. To understand all this, we should start with the basics, and we will focus today with suboptimal main vessel stenting and the problems coming from the acute side branch compromise. But to understand it, we need to understand biology.
Thank you very much, Goran, and thank you to everybody to join this webinar. Dejan and I will try to set the scene for what we will be discussing, and the basics in this is actually that when we do stenting, we use a tubular device, which actually have the same diameter in both ends. But as you can see from this cartoon, a bifurcation, when you cross a side branch, have not the same diameter in both ends. And that means that if you should fit the stent, the device, to the biology of the patient and the vessel, then you have to manipulate the stent. And there's certain risk involved. But again, if you look carefully to the cartoon, you'll see that the distal diameter is smaller than the proximal diameter. So there are considerations here on with which pressure and to which diameter you should actually inflate the balloon and implant the stent. This is some of the very first basic steps in provisional stenting. And Dejan, I think I will pass this over to you to elaborate a bit more in what happens when we put in a stent, like we can see in this cartoon, which is not corrected, implanted. What happens, and go into details there. And on the right panel here, we can see what happens if we actually pay respect to the different diameters and manipulate the stent so it fits the biology. But Dejan, I would like to pass it over to you here to discuss exactly what happens.
Yes, thank you very much. So what's really important is that we are here in a provisional webinar. And as we know, provisional is basically bread and butter of bifurcation PCI. A great majority is performed of bifurcation PCIs is performed in the provisional. And the intention of provisional is to finish the procedure with one stent. What we should do is not underestimate provisional. As you will see throughout this webinar, there are several pitfalls, several procedural mistakes that we can do throughout performing provisional that we should really try to avoid, and if they happen, we should try to correct them. The very first mistake that we can do is to size our stent according to the proximal segment of the bifurcation. As Professor Lassen nicely pointed out, stent has one diameter. So the working stents that we have at the moment on the market, most of them have only one diameter, and that's it. And the bifurcation has different diameters, as we saw. So placing a stent or picking the stent size that is according to the distal reference diameter is what we want. That is our goal. If we do not do that, the clinical consequences are here depicted on this slide. This is a real case from a cath lab showing an operator who decided to size a stent according to the proximal reference diameter. What happened, as you could see on the previous slide, is that the carina shift, together with the plug shift in this case, and the fact that there was some disease at the ostium of the side branch to start with, all of them contributed jointly to the fact that we have acute side branch loss. In fact, in this very case, side branch was never recovered. So this is the very first mistake that you can make when performing provisional, and that is not to size the stent correctly, and the correct sizing is according to the distal reference. Now, sizing a stent according to the distal reference creates the natural problem of not having an adequate result in the proximal segment. And you see this on this slide, and we have been talking about POT for some years now, and POT is the solution to this problem. So you consciously undersize your stent in the proximal segment as a consequence of sizing it according to the distal reference diameter, and by doing that, you necessitate another next step. And a logical another step is to use a short balloon with a distal balloon marker placed in front of the carina to correct the underexpansion, but not only to correct it, but also to free the side branch ostium at least a little bit of the obstruction by the metal, which is coming from the crossover stenting. And as the last slide in this series, this is basically the introduction of the first part of the webinar, and that is what are the pitfalls that are connected with POT. So what you can do when you're performing POT is that you place the balloon too deep. And you see on the left-hand side of the slide in green, the way it should be done, with the distal reference, with the distal marker of the balloon at the place of the carina. And you see on the right-hand side of the slide, the way it should not be done. This is a POT too deep. The balloon that is positioned too distally, it goes over the carina, which in fact undoes what the POT should do. It once again jails the side branch, and it moreover can create malposition in the proximal segment that you see here at the little red dot numbered 2. So potting too deep is not what we want. This is one of the major pitfalls that we can do. And I would ask Professor Lassen to show us how it looks in vivo.
Thank you very much, Dian. And we have these nice pictures from the Visible Heart Lab in the University of Minneapolis and from Medtronic, showing the stent inside a reanimated pig heart. What we see here is actually a reverse provisional. And as you can see in the bottom of the slide, below the balloon, there is not a carina in the middle. This is the POT balloon, and you can actually, at this panel, see through the balloon and see that the balloon tip is way below the carina, and the marker has not been placed as we advocate. And as you can see here, it seems that the carina has changed toward the side branch again. And if we move forward on this, you can, in this picture, which is a still picture, easily see that now we do have some access to the main vessel, but the access to the side branch is actually hampered. So this is exactly what...
Yes, can I just interrupt you for a second? I think very important question came from Dr. Manoukian. Some operators remove side branch wire before POT. Is this acceptable?
Well, this is not a very good idea, and I think that we can answer that question easily later in this webinar, where we have a clear example why the jailed wire is extremely important. It is actually our safety line. So we don't recommend to remove the jailed wire before POT. We strictly recommend to keep it in place. And it was an excellent question, actually. So thank you. If we go back to the POT too deep, we can see that here we have another complication, and that is actually that we didn't really have the carina in the middle as we supposed, and it was very, very nicely depicted by Dejan in the cartoon just before. You can maybe also see that there is some gap proximal in the proximal stent part. Bottleneck, it's called, and it's part of the problem as well. But if we move further on, we have to correct, and that actually means in this situation we do have wires in place, so it's possible to actually go back and do a kissing balloon inflation and a repot, the final pot, to correct both the carina, which now is nicely in the middle, and also to correct the bottleneck shape and the malposition in the proximal part of the stent. So this was actually what we could see inside the vessel. So now we have seen these problems both from cartoons and from the inside. So I would like actually to move forward and to you, Goran, to show us this clinical case.
No, now we discuss first, it's not good to do distal pot, but also we have to be careful to perform pot at the proximal stent edge. And I like very much these illustrations prepared by Dejan. So this really clearly shows, Dejan, maybe you can lead us through your cartoons, helping to understand what happens if we don't go all the way back, if we don't optimally dilate the full length up to proximal stent edge.
Well, yes, thank you. First of all, I would like to once again really congratulate you on the Virtual Heart Lab work, where you could in vivo see the consequences of not performing pot correctly. And I would like to reiterate what you just showed us, because this is not so clearly visible on the angiography, that you pushed so much metal towards the ostium of the side branch by performing 2 distal pot. So this is something which we could really see nicely on those Virtual Heart Lab models, and this should really stay with us, and we should really stick in our mind when we are performing pot, to really do it carefully. Now, we should also be not afraid of pot. You nicely show the complications, but we should not refrain from doing pot, because if we do that, if we omit proximal optimization after implanting a stent across the side branch, then we may be running into major problems. And you see here depicted what happens on the left-hand side is not performing pot at all. And on the right-hand side is if we perform it too proximal, if we do not expand the stent up to the carina the way we started off as an exemplar of what should be done. So what you basically create for yourself is an environment that is dangerous if you want to rewire the side branch. And you see here now, with several animations, where the wire can go, and it goes first outside the stent completely into the side branch, and then secondly, it can go inside the stent and then outside again, and then into the side branch. Pretty much the same or very similar can happen if we did pot, but not optimally, not at the correct place down to the carina. So basically, all of these problems with rewiring are going to create major problems if we are intending any kind of intervention in the side branch. And I would like Professor Lassen to once again show us how it looks in vivo, because these pictures and these moving images from the Virtual Heart Lab should really stick in our mind. It is a unique opportunity that we do not have in the cath lab.
Thank you very much, Dejan. And as we can see here, we have implanted a stent with respect to the distal diameter, and which means that the proximal part is floating. We can see the jailed wire, but we can also see a wire passing below the stent struts. And there we can see it goes behind, and it's very easy to see it goes inside and then out again in the side branch. So try to imagine what will happen if we inflate a balloon over this wire. We will cross the stent in different areas and enlarge it in others and make a huge mess of metal in the vessel.
And actually, also, you have the angiogram, and I would like to point your attention to angio, in which you don't really appreciate that wire goes in and out or abluminally completely outside of the stent. So by angiography alone, you are not able to see this, and you need to understand the specificities of the bifurcation anatomy, and need to first correct optimization of the stent in the proximal part, and then to go to rewiring. Of course, keeping a jail wire inside. Jens, I'm sorry that we removed your images, because you were the operator in this specific case, and it was really funny to look at your face with really clear surprise in your eyes, because you were not expecting actually this wire goes in and out of the stent without any resistance, without tactile feeling to transmit. What was the main message for you when you did this?
Well, the main message was actually, as you explained, that I was extremely surprised, and it took me very long time to realize that I was beneath the stent struts in the proximal part, even though I had both access to the visible heart panel and also the angio. So this was, and the tactile feeling was actually, I couldn't really feel it.
To go back to Jwire, there is a question from Dr. Ilyusha, how to overcome difficulty of Jwire retrieval after the pot, since the guide catheter tend to protrude to the vessel when you pull back the Jwire. Any specific tips and tricks you would like to comment? How to remove the Jwire and carefully watch with the left hand maneuver, watch carefully the tip of the guiding catheter. Actually, what we recommend is to completely disengage the catheter from the ostium of the coronary artery, carefully take a look on the tip of the guiding catheter with your left hand, hold the guiding catheter, and then very slowly try to remove the Jwire. In most of the instances, except in very calcified diffuse disease, usually we are able to very slowly pull back and remove the Jwire. In case of difficulty, don't forcefully insist. Please use small balloon on the Jwire, go until the level of the proximal stent edge, and just putting the tip of the balloon at the proximal stent edge will remove partially the tension and help you remove the Jwire. With new generation of the wire, with good coating, we really don't have the difficulties, and the risk of removal of the Jwire is really much lower than the risk of not having the Jwire. And I will just lead you through a case example. Can we go back to the slides? And I'll show you the case which I presented at PCR a few years back. If I can have my slides. So this is the case, baseline anatomy of the case of a patient with, as you may appreciate, bifurcation lesion, LAD diagonal, diffuse disease from the ostium of diagonal and extending in the LAD distal from the main vessel. So decision was to start as a provisional strategy, predilate LAD, stent the LAD, having a Jwire inside, and this is the result after LAD stenting, and then it was necessary to rewire the side branch. However, when we try to pull out the balloon from the LAD, of course, without enough attention, we actually completely pulled out the wire from diagonal. So you see that after stenting of the LAD, without our goal to do it, we lost the wire in diagonal. And it was extremely difficult with a lot of efforts to go back with the wire. And finally, we regained the access into diagonal. We pre-dilated with balloon. Result because of the diffuse disease was not satisfactory, so we decided to do tap stenting. And this is, you see, stent in diagonal, balloon which is positioned inside the LAD stent. And after stenting and kissing, this is, I think, excellent angiographic result. And we were very happy because we were able to regain the access. However, in 2 months, patient came back to our hospital because of progressive angina on minimal efforts. And what we see here is on the left-hand side, you can see inside the stent and proximal to the stent in the LAD, some hazy appearance inside the lumen. This was not so clear and obvious, but we also in the spider view can see. So patient came back with the acute coronary syndrome, and of course, knowing the potential reasons for early recurrence of symptoms and this hazy appearance, we did IVUS. And what we see on IBUS in panel A is actually a crushed stent against the vessel wall proximal to bifurcation. You see two lines, a red one, internal, yellow one, outer diameter of the stent. So proximally, we actually squeeze the stent against the vessel wall, and then when we move down to the level of coronary bifurcation, we clearly see that stent is nice open in the present clearly in both branches, LAD and diagonal. And on panel C, distally, we see nicer position of the stent. So what is the probable mechanism? It's most probably that trying to regain the wire access into diagonal, we actually wire diagonal abluminally outside of the LAD stent. And when we inflated the balloon, as you can see on this cartoon, we actually partially crushed the stent. We were able to perform kissing, but most probably even with the kissing balloon, with early deflation of the main vessel balloon, we were not able to completely correct stent deformation. So we did not do proper POT, we did not open and correct stent malapposition. So unfortunately, as a consequence, we had clinical event. So how to correct this one? First, we inflated balloon to really fully crush the protruding part of the stent in the proximal LAD, and then we decided to use second stent because there was also disease proximally, and you can see here kissing and final result, which angiographically again looks nice, but you remember that angiographically also during the first procedure we had optimal result. So Jens, Dejan, any comments on this one?
Maybe one comment from my side. Well, we always talk about how final kissing balloon inflation is important when there is a two-stent strategy, and that's a quality marker for a two-stent strategy of bifurcation PCI. Here, in this case, we see that's not the only quality mark, and you see how POT is important in these cases as well, because final kissing balloon inflation was performed here. It was not able to completely solve the problem that was created by the absence of POT and the subsequent abluminal rewiring of the side branch. So I think one of the main messages of this first part of this webinar, and you could see this in vivo in the models presented by Professor Lassen, is that POT is immensely important for the very acute reasons of proceeding safely with the procedural steps that are necessary for the treatment of the side branch. Of course, it is important to correct the under-expansion in the proximal segment, and this will relate to the long-term events eventually, but for the very acute reasons of proceeding with intervention, POT is really indispensable.
Thank you, Dejan. We have a couple of questions, Jens, that maybe you can address. Dr. Parlautan is asking, how about exchanging wire first from main vessel to side branch and vice versa before doing POT? Is this acceptable? So should we first exchange wire and then do POT? I think not. Maybe I didn't read it carefully, so you can understand. So we don't exchange wires. We know that we need first to optimally oppose proximal part of the stent. This will ensure that our wire will not go abluminal. So first we inflate balloon proximally, we fully deploy stent in the proximal part, and then we can exchange wires, either using main vessel wire to cross into the side branch, then removing jailed wire and re-entering distally, or we can simply use the third wire. And there is another question on POT, Dr. Iryusha.
Goran,
Yes.
Before we take the next question, I would actually like to address the first question a bit more, because it is not that difficult to remove even a stock jailed wire. We have recently discussed the small balloon technique or even a microcatheter. So we can easily remove that wire without really complications. But the jailed wire have another very, very good feature as well. because it makes actually a kind of an anchor when you would like to cross a balloon towards the side branch. And that means that there is a lot of good things by the jailed wire. It's a safety line, but it's also an anchor. So actually, we can't underline enough that do the POT before you remove the wire, because it makes the procedure much more simple, much more easy, and much more straightforward.
Yeah, thank you, Jens. Dr. Matteucci is asking which way we have for ensuring that guide wire is not abdominal. Actually, we can use stent enhancement technique, but the best way to ensure it's not abdominal is first to expand stent proximally and then try to regain access into the side branch. And another question from Dr. Cruz. For aortoosteal POT, will using properly sized semi-compliant balloon to maximally expand the osteal segment of the left main stent risk destroying the carina? No, because the most important to destroy carina is to have what Jens showed, two distal position of the marker. So aortoosteal procedure is ideal because there is no risk of proximal damage. So having distal marker position in front of the carina permits optimal stent expansion at aortoosteal position without destroying carina. So I think we should continue with our slides. If we can have slides back. Jens, please lead us to a case that we compromise the side branch after main vessel optimization and stenting.
Thank you very much, Goran. Yes, I would be very happy. We have already discussed a lot of the good things with a jailed wire. But before we run through the next part, I would just ask you to pay attention to the recently published EBC main trial, which actually showed us that there was no price to pay to do provisional start of a procedure in the left main. And this is one of the really important results, which means that you can try to keep a procedure as simple as possible and maybe end up with one stent, and there's no really risk. But of course, there are risks by doing provisional stenting, and we have already discussed a lot of those risks. Most of the risks can be actually helped out or solved if we have complications. One of the things is the POT. We have discussed that, and POT very, very early, and jail the side branch. And if we, after the POT, closes the side branch, then we have the jailed side branch wire. And what we'll go through now in the next step is actually how do we solve the problem when the side branch closes. You have this cartoon from one of the EBC consensus documents. And from the left, you can see a very severe bifurcation. You can see a stent basically implanted, it seems, with the proximal diameter as a reference. And as a consequence, we can see exactly what we have been discussing. We will push the carina towards the side branch and maybe close it. So what to do? Well, in this technique, we have the jailed wire, and we take a very small balloon and pass it over the jailed wire and pass it behind the stent struts down to the takeoff of the side branch and inflate it. By doing this, it's possible to recreate flow in the side branch. Then, when we have flow, we can rewire and we can do the POT again, and then we have access to the side branch. So this is a very, very important technique that makes the provisional pathway really safe and simple. But it's not that easy a technique, so it's a technique you should know, and a technique you should master. Because when we have the problems, it's very nice to have a tool to solve them. And I think we should move forward and show you how this would work in a visible heart lab, where you can see actually what happens. And Goran, I think you were the one who took care of that one.
Yeah, it was together with Francesco Burzotta, and these are nice images that he put to explain and help our colleagues better understand. So you see in the center there is a stent and a balloon non-inflated inside the stent, and on the jailed wire you see small balloon. This is just 1.5 millimeter balloon, and look, when we go outside of the stent on the jailed wire and we inflate small balloon, how much stent deformation we actually create. So for that reason, whenever we try to recover flow inside the side branch, the first step is always to go with non-inflated balloon inside the stent inside the main vessel, because we need to preserve access to the stent and to protect the main vessel. And then we go on the jailed wire with short 1.5, 1.1, the smallest balloon that you have behind the stent. Because of the fractal geometry, there is always some space outside of the stent which allows us to go and then inflate it. After inflation of the jailed balloon, re-establishing flow, we need to correct this deformation. So after inflating jailed balloon, we actually remove balloon from the jailed wire and we carefully inflate a balloon for pot that was positioned inside the stent. And you see that now we have flow in the side branch and we actually corrected the case. And I'll show you again one of the cases from our lab. We did it together with Dr. Dejan Orlic, and this was a true distal left main bifurcation with predominant lesion in the ostium of the LAD and the distal part of the left main. Decision was to do provisional crossover stenting. There was no such significant lesions, just some plaque at the ostium of the circ. So our strategy was, as usually, because of the long left main, not to cross over until the ostium, but to cross over enough to have place within the stent in the left main to do pot. So stent was selected according to LAD diameter. We inflated balloon. You can see position of the stent from left main into the LAD. And after inflation of that balloon, this is what happened. Circumflex completely disappeared. We were very happy to have a jailed wire. And I would like to ask Dejan and Jens if you had similar experiences, and how do you feel when in such a large circumflex you lose it completely, patient starts having chest pain, you see ECG changes on the monitor, and frequently you see also some hemodynamic compromise, and you need to do recovery. So what would you do next?
Well, you described the situation so well, Goran, and I guess we have been in that situation, all of us. I think my first reaction is actually how I avoid my glasses being damp, and to bring my own heart rate a bit down again, and then realizing that the patient, not only because of the closed vessel, but also maybe because of impairment of the papillary musculature, have some mitral regurgitation and deteriorates very quickly. So this is really, really, really risky. Of course, the first that comes to one's mind is try to rewire. And there's many options here, but this is, of course, where you really like to have a toolbox, and you have a plan B and a plan C and a plan D to fall back to. Because somebody could actually see this is so severe a complication that you actually need to call the surgeons. You need to maybe go to extracorporeal circulation or whatever. But of course, there are solutions. But Dejan, well, I guess you know the sweaty situation as well. So
yeah,
it's
not a pleasant situation to be in, I guess. But I find it interesting. We actually posted this prior to this webinar on Twitter, And we have received many responses. And if I could divide those responses into 3 categories, it would be like this. And I think this is a good answer to what the next step would be. The first category of answers is that we should immediately do the repot, that we should pot again and then see what happens, and maybe then proceed further. The second category of answers was mostly related to the fact that we need to rewire quickly, and that we should use different devices to help with this, like dual lumen catheters, etc. And the third line of responses was related to the clinical condition of the patient in terms of a hemodynamic compromise that could be possible, and that we should first take care of that. So these are 3 lines of argument that we received as answers on the Twitter, and I would just add that I would consider them all very valid. To me, the first step would be to wait a bit. If the patient's condition allows it, maybe to wait a few seconds and then give another shot of contrast and hope that you will then see the side branch. If you still not see it, then I think that the first degree of eminence, so the preeminent next step would be then to recover it, because it's really hard. And we have several options in our mind, which I think are going to be shown now by Professor Stankovic.
Yeah, thank you. Thank you very much, Dejan. It was really sweaty, as Jens said. So we had to work very fast. And if we can have back our slides. So we already showed you how to use a small balloon advanced over jailed side branch wire. And you can see this yellow dot, and you can see balloon going on the circumflex wire. Here, the tip of the balloon just entering into the ostium of the circ, and even without inflating that balloon, you can see that just simple passage of the balloon on the jailed wire was adequate to visualize the circ and to reestablish the flow into the circ. So after this, as many of our colleagues also suggested today, we knew for sure that our wire in the LAD was inside the stent, so we decided to use dual lumen catheter on a wire which is inside the stent, so we know for sure that we are inside the stent from the beginning, and we used over the wire lumen that you can see here to cross and wire the ostium of the circ. Using that dual lumen catheter allowed us to make sure that our wire is not going outside abdominally and is not going in and out. So use of the dual lumen catheter should be practiced, but after some practice we really ensure that we are able to cross in difficult situation. And the next steps after rewiring, after knowing that we are inside the circ, so first we inflate balloon, we open access, remove jailed struts from the ostium of the circ, and we did upsizing of the balloon, and we did proper kissing balloon inflation. So in order to correct ostium of the circ, you first inflate balloon with smaller balloon to make sure that you can cross through the struts, and then you use adequately sized balloon to perform kissing. The way we did this kissing, I can share with you at least what we learned from bench. We start by inflating side branch balloon first, then we inflate main vessel balloon, and at the end of the kissing balloon inflation, you keep increasing pressure in the side branch balloon, which has the goal to push some metal and scaffold the ostium of the side branch, in this case the circ. So we start by inflating side branch, we have similar pressures then in both balloons, and finally we slightly increase balloon pressure in the side branch in order to push some metal and scaffold the ostium of the side branch. And this is the final result after crossover, stenting, and kissing. In our view, this result was angiographically optimal. So we were able to cross the distal strut, we were able, by kissing balloon inflation, not only to remove the metal, but also to push some metal from the main vessel stent and scaffold the ostium of the circumflex. So we did not have huge residual stenosis, and we had TIMI-3 flow, and we were quite happy with this result. And after that, patient's clinical outcome was optimal, and he came back for follow-up visits free of symptoms. So I think it's very important to again go through the steps of the side branch rescue or salvage technique. There are 4 steps. First step, please keep in mind inflation of the jailed balloon always creates stent deformation. So step number 1, always put balloon, which you will use for pot inside the main vessel. Step number 2, you go with rescue balloon on the jailed wire. 1.5 balloon goes easily in most of the instances. You can inflate that balloon. After inflating balloon, you reestablish flow. You can clearly first decrease patient symptoms. You can see the ostium of the side branch, and then you can, in order to be able to rewire, you need to inflate balloon, which was from the beginning positioned. It's number 3. You restore flow, you redo pot, and step number 4, proximal inflation to correct deformation created by the jailed balloon. So we feel really relaxed that this works, and this works also in the left main, and keeping this option in mind really helps us put in the perspective the EBC main data on suggesting provisional. Jens, how can you put this in the perspective that now we have good 1-year clinical outcome results from EBC main, but we need to be aware of potential pitfalls, and we know that we have solution also.
Yeah, you're totally correct, Goran. And maybe we could go back to the final result of your balloon rescue case with the circumflex flex preserved. If you could go back to show us that again.
Yes, I'm trying to go back. If we can have slides. And this one.
Because I think we should have a short discussion and maybe take some questions when we have these pictures running, because this picture is actually the scary thing for an interventionalist. And this is one of the reasons you lose circumflex, and it's really, really not good. So this is one of the reasons for most operators to choose a 2-stent technique from the very beginning, because maybe DK cross is cumbersome and complicated and take times and leave a lot of metal in different places. But it is pretty safe to do it with the acute result. And this is actually the perception that most operators have. But that makes it totally impossible to end up with 1 stent. And if we really believe in the concept that keep it simple, reduce the metal in the coronaries, and keep every important vessel opens, then we need to go provisional. But we can't go provisional if we are filled of, if we are afraid of losing side branches. So this is actually a dilemma, and this is a philosophy. But this picture of the circumflex shows us so nicely that even though the circumflex was lost, even though there was a lot of disease in the first of tussus marginal, that was actually solved by the rescue technique and the Pogadon. So there's no disease in the really left, not stenosis at all, in the first of tussus marginal, and we have an extremely nice result of the left vein with only 1 stent. And this is actually an extremely important message. And the reason for having such a nice result was that the operator was capable of solving the closed side branch problem and solve it with a very easy technique when you master it. And I think this.
Thank you. Thank you very much, Jens. I think these comments are excellent. And in the meantime, while we are discussing, we received multiple questions coming from our colleagues. So if you can take some of those questions and actually share with us your own practice. Dr. Matteucci and Dr. Ilyusha are both asking, do you consider occasional use of gelling balloon technique, or in case of tight and long ostial side branch lesion, jailed wire only or jailed balloon technique, which is more favorable to avoid side branch occlusion? So in general, questions are, should we keep our protection of the side branch just by gelling wire, or there are some situations in which you also jail balloon, or you have multiple variations of modified jail balloon techniques? What is, in your experience, Dan and Jens, the role of jailed balloon in contemporary PCI practice?
So I usually do not use jailed balloon technique. I just jail the wire. The problem, or the potential problem that I see with using the jailed balloon technique, is the gross distortion of the main vessel stent that I'm implanting. And the benefit, the perceived benefit, would be that I would have more opportunity to save the side branch, and that I would have less risk to lose it. And to that, I think the response is first the case that we showed. So just by having the jailed side branch wire in place, it could already serve as a safe line, as was said, to rescue the acute loss of the side branch. But also conversely, I do not think that we should totally refrain, and that's only my humble opinion, from two-stent strategies up front. I mean, we use a provisional strategy in most of the cases, in the great majority of the cases, but there will be cases with the extensive calcified disease of the side branch, of a very large side branch, where we would upfront decide for a two-stent strategy, and then maybe stenting the side branch first would also give us the maximum security of not losing it. So to me, at least in my opinion, the jailed balloon technique may increase the risk of irreparably basically distorting the main vessel stent. And as we know, the main vessel stent is probably the main driver of the long-term outcomes when considering bifurcation PCI.
Yeah, if I can add on those excellent comments, also publication from, again, Dr. George Sianos and Francesco Burzotta in Neurointervention several years ago, when they introduced the concept of the jailed balloon technique. They jailed 205 balloons, and they had to inflate only 2 times. So you use 200 balloons to inflate only twice, and having now a really well explained rescue technique using jail wire only, I don't believe that jail balloon significantly adds to safety of the procedure. Jens, any comments on that from your side?
Yeah, well, a lot of comments actually, because I think this is an extremely important discussion. First of all, I don't use jail balloon in my practice, or we don't do it in my institution or in any of the institutions I've been in, and there's several reasons for that. The main reason is actually what you just said, Goran. It's very, very seldom you need it, and then you have it. But actually, when you use a jailed balloon technique, it's more difficult to make a proper pot. And that's actually the most important thing. So if you really carefully implant the stent with a proper pot, then the risk of losing the side branch is not that high. And then you don't need the jailed balloon. And we have easily shown how easy it is to actually go behind. Even if you are not able to pass a balloon on the jailed wire, you can always pass a microcatheter, and after that a balloon. So this is actually a clear way forward. And so this was the jailed balloon technique. It's nice to know, and it's nice to know it's there. And I won't say there won't be a situation where you could consider it. But the only thing where I really would consider it is if it's a high-risk procedure where I need to do it quickly and don't need to, put patient at high risk. But then I would definitely not use a jailed balloon, because that will increase the procedure time. So,
okay.
Well, I think it's an interesting concept, but we don't use it. The other comment is actually...
We don't practically use it, yes.
No, we don't. But the other thing is actually, when there is a reason for two stents, and I totally agree with you, Dan, that of course we can use two stents now and then. But exactly the case you described, where you have calcified side branch. It's actually very easy to do a reverse provisional, and then see if you need. But of course, if it's a 0, if it's a 1-1-1, there will be a situation where it really will be good to do it. But if you have your toolbox in place, you can always do 2 stent techniques from a provisional pathway.
Yeah.
So,
I think it's a good moment to try to explain at least our personal position on this issue of should we protect and how should we protect side branch if there is some disease or if there is diffuse disease. Most of the steps in our bifurcation PCI are driven by our fear of losing the side branch. So I believe that clear demonstration today, even in the most important physiological scenario of losing codominant circumflex, having the option to rescue the side branch with jailed wire and balloon on the jailed wire, or in case of difficulty, you can use a microcatheter if balloon does not cross. So having Corsair, for example, could help you to go also behind and visualize and reestablish some flow to improve clinical condition, to have less ischemia, and to work peacefully. I believe that all this in our toolbox, as you said, are very important tools in recommending provisional as a strategy for majority. But also in case, as you said, that there is diffuse disease of the circ, which is big vessel, inverted provisional or reverse provisional with contemporary DES, which can really open if you use adequately sized stent and if you know expansion capacity. You can really start by stenting from the left main into the circumflex, even with slightly oversized stent if necessary, with low pressure deployment. But of course, you need to be very careful and you need to be experienced in recommending this technique, and then optimize proximal part within the left main, do kissing, because in left main we really recommend to remove metal, jailed metal from any of the branches, because I agree with Professor Ludwig that there are no side branches in the left main bifurcation. So I would like to address him directly, because he was very suspicious whether we will recover also Ramus branch. Yes, we were able to recover all the branches and we were able to achieve optimal final result by using dual lumen catheter to ensure that we can cross. And I like the comments very much of, let me see, Dr. Matthias Brandt. He said also dedicated catheter, super cross 120 degrees could also be possible. So deflecting catheter with predefined angle that may help you point towards the circ. There are multiple maneuvers that we need to practice and we need to present to colleagues, which help us follow a layered stepwise strategy, because we know what are the limitations of provisional. We are aware of the importance of stent optimization at the first place. And Jens, there was a nice question I think we didn't have time to discuss because it was sent earlier also by Dr. Brandt. There is a study data comparing pot side pot with kissing balloon inflation with slight benefit for kissing. Is there any specific side branch angle where pot side pot is a better solution than pot kiss pot? In your practice, do you use strategy of pot side pot?
Very, very seldom. But of course, if it's a total 90-degree takeoff, it is feasible. But I think, again, to Dr. Brand, it's an excellent question. But it comes back to the problems in correcting precisely when you do pot side pot, because it's difficult to make the pot correctly. But doing the side branch dilatation, you will always have some malposition of the opposite vessel wall from the carina. And you need to correct that with pot, and that forces you to go deep with your pot, and then actually, at least by angio, make it difficult. So it's a difficult procedure to do side pot precisely. So this is one thing, and it's a very easy procedure to do a kissing and then a more proximal pot, which because you have the two kissing balloons in the main vessel. So this is the more theoretical reasons for going that way. But I won't say that I would never do pot side pot. There could be some areas where it's feasible, but maybe it's more often that I don't do nothing but implant the stent and do the pot and nothing more, and just leave some struts across a side branch if it's not too big a side branch. So I more often actually do nothing than I do pot side pot.
Yeah,
maybe there is one
also. Yeah, please, Dan.
Maybe a short comment to this, because I think it will very much depend on the size, on the diameter of the side branch. Because if you need to use a bigger balloon, the bigger balloon into the side branch will distort the opposite wall of the main vessel stent much more than a small balloon. So if there is a large sized side branch, I would tend to refrain from doing pot side pot. If there is a small side branch which is long, so you think it is valuable clinically, then I may do pot side pot, knowing that the small sized balloon will not distort the main vessel stent as much, and I can always repeat the pot and hope, as Professor Lassen said, that I will be correct in performing it.
Yeah, thank you very much, Dan. Excellent suggestion also comes from Dr. Islam. Any IVUS uses by explaining these technical tips and tricks for solving and rescue the side branch, we forgot to comment on really routine use of imaging throughout the left main PCI procedures nowadays. I believe that we have enough evidence coming from various studies, the most recent one from British Cardiac Intervention Society, which really clearly demonstrated that by increased use of imaging IVUS to 50%, they were able to demonstrate decrease in heart clinical outcome, even decrease in mortality. So as European Bifurcation Club and one of the lead first authors of several recent documents, Jens, I would like to ask you to elaborate on the position of EBC on image use in left main PCI, provisional versus two stents.
Well, it's very easy done, because we have emerging evidence that imaging makes it more easy, and we have also in this webinar showed you how much we learn when we see the visible heart laboratory. In our recent consensus documents, the general consensus documents, we actually advocate to use imaging if the procedure don't run smoothly. And this was just to acknowledge that if it doesn't really work, take a look and see what's wrong, because then it's more easy to correct. And then we actually make the OCT and the IVUS general consensus documents with a lot of our friends in the other clubs. And out of that, the position changed to underline that the more imaging you use in the high-risk procedures and in the left main procedures, the more you know about what result you actually do. And it's very, very nicely to see that we now have evidence from the British Society that it seems to improve outcome as well. So, but still, we also have to acknowledge that in some areas of the world, it's also a problem with the cost. So, exactly. Of course, in the best of all worlds, we should use imaging as much as we can, but there are some areas where
Thank you very much, Jens. I think, unfortunately, time is to conclude this webinar. We need to go to slides back again just to comment on the importance of proximal optimization. I think it's clear that because of fractal anatomy, proximal optimization is mandatory step, and in case that side branch loss occurs, POT will help to prevent it, but also we need to know that there are easy and practical side branch salvage techniques which may help us to recover lost side branches, and we believe that provisional, with all these pitfalls, is still the strategy of choice for majority of bifurcation PCIs, including the left main. So I thank you to both of you for excellent comments and for your efforts to answer the questions. I thank all our participants in this webinar. It was really a pleasure to receive your questions, and thank you for putting this on Twitter as well. And I believe that if we go to the next slide, I left intentionally. The next webinar will deal with the third pitfall, what to do if after all these efforts, after kissing, we still have inadequate final result in the side branch. On 22nd of July, we will discuss with Adrian Benning and Francesco Burzotta the tips and tricks in T and TAP. And I thank you very much for today's webinar. I thank very much Vetronic for supporting this series of educational webinars on bifurcation PCI, and the PCR for making this possible. Thank you very much. Have a good day, and looking forward to see you all in 3 weeks from now. Bye-bye.